Connect India Foundation, I extend a very, very warm welcome to you from India today. As we know, November is celebrated as Lung Cancer Awareness Month across the globe. During this month, different organizations highlight the need for lung cancer awareness. From India, Lung Connect India Foundation has taken on this responsibility to raise awareness about lung cancer and the need for patient advocacy. And this webinar is our effort to raise awareness about the need for patient advocacy and how collaboration can help strengthen the cause of patient advocacy. What is Lung Connect and who are we? Let me quickly take you through this, about Lung Connect. Globally, patient advocacy and support groups have helped advance science patient care. However, this is an unmet need in India. This is when, in 2018, a few advocates, patients with lung cancer, caregivers, survivors, and those living with lung cancer came together to form Lung Connect India Foundation, a support group, rather an advocacy group aimed to empower patients with lung cancer and their families through correct information, resources, and support. We are one of its kind lung cancer support and advocacy group in India, and we are very proud to say, not only in India, but all of Southeast Asia. Till date, we have conducted 125 support group meetings on the trot every month without a break. Come rain, hail, sun, or storm, we are there for our patients every month. Let me quickly take you through the different activities that we've been involved in. I know this is a very small step towards advocacy. We have a long way to go, but I'll just quickly run all of you through what we've done and achieved till date. During COVID, when the lockdown was announced, a lot of our patients live in rural India. They were lost, especially the ones on the targeted therapy medications were frantic and they panicked. Our team got multiple calls and a lot of them said they were going to die. We couldn't leave them alone. That's when our patient navigators, our team, along with the oncologists, joined hands, and we were able to successfully, through the only courier service available in India at that time, get medicines delivered to their doorstep. Patients at end of life, those who are dying of lung cancer, who live in rural India, have been very successfully connected to local palliative care centers. Palliative care is still very niche in India, but we do our best to help those who are dying die pain-free and with dignity. The patient advocates from Lung Connect India have successfully written to the Government of India about the need for inclusion of funding of molecular panel testing, targeted therapy drugs, and diagnostics in the Ayushman Bharat scheme or the Yojana. This is one of its kind national insurance scheme given by the Government of India for the underprivileged. But unfortunately, it does not cover the cost of the molecular panel testing, targeted therapy drugs, and the diagnostics. And we are striving to get this done. A petition signed by 800 patients and caregivers has recently been given to the Ministry of Health. Through advocacy, in the state of Jharkhand, cancer has been listed as a notifiable disease. In the same state, the funding for lung cancer patients has now been increased to 10 lakh rupees. This has been possible due to the advocacy efforts of Mr. Ravi Prakash Jharkhandi, who was a stage 4 non-small cell lung cancer patient who unfortunately died a few months back. May his soul rest in peace. The entire team of Lung Connect India Foundation is striving to convince the Government of India to include cancer in the list of notifiable diseases. One of the USPs about Lung Connect is our navigators. Our navigators, they actually work very closely with the oncologist and help the patient and the caregivers navigate the complex landscape of lung cancer from the time they put their foot into the hospitals. Our navigators are trained in financial counseling, in providing logistic support, and any other resources that the caregivers and the family may need, and the patients may need. And just to brag a little, or just to tell you all this is done free of cost. Not a single penny is charged. Lung Connect India Foundation has become the largest community of lung cancer advocates, patients, and we strive to raise the voice of those who've been fighting with lung cancer. I have a very interesting panel discussion lined up. We have two panels. My first panel consists of an amazing cohort of people. We believe that till we voice the concerns of those who are dealing with lung cancer, our efforts are not going in the right direction. So my first panel consists of people who have experienced lung cancer very closely. They are the ones who have, some of them are living with lung cancer, a few are in remission, and some are the caregivers to people with lung cancer. As illustrated by the phrase, nothing about us without us, we believe decisions about people living with lung cancer should not and cannot be made without suitable representation of their views and perspectives. With that, I present to you panel one. The panel one has 5 people in it, and I am going to invite my first panelist, who is Ms. Rasika Bombatkar, a 28-year-old physiotherapist living with stage 3 non-small cell lung cancer. Rasika is going to take us through the challenges she's faced since diagnosis. Thank you, Rasika, for being here with us, and over to you.
Thank you for the kind introduction, Vandanaji. Yeah, as you said, being diagnosed with stage 3 lung cancer at 26 years of age was a huge shock for me. I think there were two main reasons why I was directly diagnosed at stage 3 and not earlier. First, I had no symptoms initially and was fit and healthy, so I didn't feel the need to worry at all. And secondly, when I did develop a cough that lasted for weeks, I ignored it, thinking it was something minor. I believe many young people tend to dismiss such signs which contribute to late diagnosis. This diagnosis deeply affected both personally and professionally. On the professional front, my career came to a sudden halt. I had to leave my job and focus entirely on the treatment. For a long time, I couldn't even think of returning to work or making future career plans. On a personal level, it impacted my relationships with my family. I had to strongly oppose their pressure to try alternative medicines like drinking cow urine and eating grass in the hopes that this will cure cancer. I also began questioning my future, especially around marriage, relationships, wondering if the diagnosis meant those parts of my life were no longer possible. Even though I work in healthcare, I'm a physiotherapist, and I'm well educated, I realize how difficult it is to escape the stigma and societal norms surrounding cancer, especially as a young woman. And that's why I believe we need to increase awareness about lung cancer, not just the medical side of it, but also the emotional and social challenges patients face. And that's why I'm here today sharing my story in the hopes of bringing attention to these aspects of living with lung cancer. Thank you for providing me this opportunity.
Thank you, Rasika. Your voice matters, and it is through Lung Connect we want to raise the voice of other people like you, so that we can collaborate, join hands, and bring about the much needed change. The next panelist for the day is a caregiver. His name is Mohammad Rizwan. We call him lovingly Rizwan Bhai. Rizwan Bhai's wife, Sana, is living with stage 4 non-small cell lung cancer. She has a ROS positive fusion mutation. Rizwan Bhai is the primary caregiver to Sana and his 9-year-old son. He's going to tell us his challenges post-diagnosis. Rizwan Bhai, thank you for being here.
Thank you so much, Vandana ji, for providing me a platform. So I came from a society where this cancer is called bad disease. So imagine when my wife was diagnosed with this so-called bad disease, what impact would have been when we got the diagnosis. Right. So the moment we got diagnosis, we are clueless where to go, how to get treatment. Finally, we decided to go to the Tata Memorial Hospital, which it at Mumbai, which is again 1500 kilometer away from my stay location. So I'm doing a job. I'm a chemical engineer. So I took a leave for 1 month during diagnosis period, and I stay with my wife because this disease required a person accompanied with the patient. I'm doing job. I was fortunate that I got a lot of support from my employer, but through Lung Connect, I know very lot of person like me who face a lot of challenges for getting leave. Their job get impacted, their promotions, everything got impacted. They are getting problem in getting the leave on time for regular follow up job. The next challenges I face is the cost. The targeted medicine crizotinib that my wife is taking, it costs around more than $1,000 per month. Still, it is a huge amount for me to manage in every month. Anyhow, through patient assistant program, through insurance I have, and through my employer, I able to manage it. But what about the other person, other caregiver who doesn't have such support like insurance and all? How to manage that money? If the medicine is there, it should be affordable enough so that people like us can afford that medicine, right? Another thing is that for every 2 to 3 months I have to go for follow up at TMH and stay for 4 to 5 days. During those period I have 9-year-old son, and I'm really worried about their mental stress and their study, so that it should continue while we go for a follow up and all. So I have to manage anyhow for their continuation of a study, so that he should stay at home in our absence, and he should continue on the study. So these are the challenges a caregiver, a working person like me faces. And my appeal to the government and the pharma industry to make these medicine affordable to all, so that we do not have any option and we get chance to for equal treatment. Thank you so much for the platform. Thank you.
Yeah. Thank you, Rizwan Bhai. Your struggles are real, and you not only speak for yourself, you speak for the millions of caregivers who take care of their loved ones diagnosed with lung cancer. Thank you once again for being here. I now invite Mr. Ashok Kumar ji, who's our next panelist. Ashok ji is 63 years old. He's recently been diagnosed with lung cancer. He is a retired manager from the bank, chief manager from the bank, and he lives in the state of Jharkhand. Ashok ji will tell us about his struggles living in a small town of India post diagnosis. Thank you, Ashok ji, हमारे साथ जुड़ने के लिए.
इस प्लेटफॉर्म में मुझे आमंत्रित करने के लिए बहुत बहुत धन्यवाद। मैं एक राष्ट्रीय बैंक से सेवानिवृत्त अधिकारी हूँ। सेवा काल में मुझे स्वास्थ्य समस्या नहीं थी, अर्थात मैं कभी भी लंबी बीमारी से ग्रसित नहीं हुआ। इसी साल अप्रैल में जब मुझे लंग कैंसर का पता चला तो मैं स्तब्ध रह गया। एक साधारण सी ठीक न होने वाली खांसी और टेस्ट कराते कराते कैंसर, 10 दिनों में ही मेरी दुनिया बदल गई। मुझे अल्क पॉजिटिव है और इसका इलाज बहुत महंगा है। मैं लॉर्नाटिनिब ले रहा हूँ। इसकी 15 टैबलेट की कीमत 1,50,000 है और मुझे टीएमएस से 1,28,000 रुपये में मिलता है। मुझे एक माह में 2,56,000 तथा एक साल में 31,72,000 खर्च करने होंगे। रिटायरमेंट के समय प्राप्त पीएफ तथा अन्य बचत, होम लोन और अन्य देनदारियों को चुकाते चुकाते मात्र 5-7 लाख रुपये रह गए। मुंबई आने जाने, खाने पीने, ठहरने तथा टेस्ट में पहले ही बहुत खर्च हो चुके थे। दवा के लिए अपने छोटे भाई से सहायता लेना पड़ा। हम जैसे मध्यम वर्गीय लोगों के पास पर्याप्त संसाधन नहीं होते हैं। भविष्य में दवा खरीदने के लिए मुझे अपनी जमीन बेचने के अलावा कुछ भी नहीं दिख रहा था, अतः इसे बेचकर रुपयों का इंतजाम करना पड़ा। इस प्लेटफॉर्म के माध्यम से मैं यह कहना चाहता हूँ कि लंग कैंसर हर किसी को हो सकता है जिसके पास लंग है। मैंने कभी सिगरेट नहीं पी, शराब का सेवन नहीं किया, फिर भी मुझे लंग कैंसर हुआ। मैं सरकार से अनुरोध करना चाहता हूँ कि इसकी दवा की कीमत को घटाने के लिए उचित कदम उठाए ताकि यह सबके पहुंच में हो जाए। इसे एक गंभीर बीमारी मानते हुए आयुष्मान भारत में सम्मिलित करें तथा मध्यम वर्ग को भी इसका लाभ प्रदान करें। एक बार फिर से सभी को बहुत बहुत धन्यवाद।
Dhanyavad, Ashok ji. Thank you, Ashok ji, for being here today. Now, before I invite my next panelist, I want to tell you why we have Ashok ji and our next panelist here. India, as we know, is a very culturally diverse country. Not all of us, not all the people in India speak English or Hindi. Ashok ji and my next panelist here are here to talk about their struggles in their own language, because language barriers also are an obstacle for getting the right treatment. Now, with that, I invite the next panelist, Shreya Burman. Shreya is the caregiver. Shreya is 24 years old. She's the caregiver to her mother, who's just been diagnosed with stage 4 lung cancer. And Shreya's mother has a red positive fusion mutation. Shreya, आप बताइए your struggles.
Go ahead, Shreya.
ধন্যবাদ লং ক্যানভেট আমার ইন্ট্রোডাকশন দেওয়ার জন্য। আমার মা 53 বছর বয়স, লাং ক্যান্সার স্টেজ 4 রেড ফিউশন পজিটিভ। এটা আমার মায়ের ফার্স্ট ডায়াগনোসড হয়েছিল 2023 নভেম্বর মাসে। তারপর থেকে আমি এবং আমার ফ্যামিলি মেন্টালি খুবই ভেঙে পড়েছিলাম। তারপরে আমরা ডিসাইড করি যে আমরা ট্রিটমেন্টটা স্টার্ট করবো টাটা মুম্বাই হসপিটালে, এবং তারপর থেকে অনেক চ্যালেঞ্জেস আমাদের ফেস করতে হয়েছে। ফার্স্টলি তো এই হাওড়া থেকে মুম্বাই এসে এতটা দূরে এসে ট্রিটমেন্ট চালানো আমার এবং আমার ফ্যামিলির পক্ষে প্রচন্ড প্রবলেম হয়েছে। এবং আমার দাদা একজন রেলওয়ে সার্ভিস করে, তার দরুন আমরা কিছুটা ফেসিলিটিস পেলেও যে হাই কস্ট মেডিসিন আছে সিলভার ক্যাটাগরি, তো সেইগুলো আমরা অ্যাফোর্ড করতে পারছি না। আমার বৌদি হচ্ছে 9 মান্থস প্রেগনেন্ট, এবং তার ফলে এবারে আমার দাদা আসতে পারেনি। তো তার ফলে আমরা দুজন মেয়ে হিসাবে আমাদের এখানে থাকা খাওয়া খুবই প্রবলেম ফেস করতে হচ্ছে। এবং আমার মায়ের কেমো নেওয়ার পরে অনেক সাইড এফেক্টস হয়, তো সেই জন্য মা প্রচন্ড কষ্ট পায়। যদি এই ওরাল মেডিসিনগুলো আমরা অ্যাফোর্ড করতে পারতাম, তার ফলে কিন্তু আমাদের অনেকটা সুবিধা হতো। কাইন্ডলি যদি এই দিকগুলো একটু দেখা হয়, এবং সেটাই আমি আমার গভর্নমেন্টকেও সেটাই জানাতে চাই। থ্যাংক ইউ।
Thank you, Shreya. Just for the ease of everyone who's here and who do not understand Hindi and Bengali, I'll quickly summarize what Ashok ji and Shreya shared. Ashok ji essentially spoke about the high cost of lorlatinib medication. He had to sell his land to buy this medication. He says after a certain point, he'll run out of funds. What then? He's appealing to the government of India to include such life-saving, costly medications in the insurance schemes. Shreya highlighted how, as a young woman, she had to travel from West Bengal to Mumbai for the treatment of her mother. Her mother has recently been diagnosed with stage 4 lung cancer, red mutation. She says the cost of the medication that has been advised to her mother is unaffordable. First of all, it's not available in India. Even if it was, for them to get it in India is humanly impossible. As a woman, 2 women traveling alone, finding lodging, a place to stay is such a huge challenge for them. They live in a government, they're from the railways. So she says the railways given them room only for 3 days. What after that? So there are many, many challenges that people diagnosed with lung cancer face in India. I'm quickly going to summarize what the entire panel here said. First, I want to thank each one of you who have spoken about your challenges. It is not easy to come on a public platform like this and talk about your struggles, the struggles your families have faced. And we at Lung Connect salute you for your not only resilience, your fortitude, but for your willingness to be the voice for not only yourself, for the millions of other Indians who can't speak or raise their concerns. Thank you all for being here. I'm just going to quickly summarize what they said. Number one is, like Rasika said, the entire panel here I want to highlight is of non-smokers. They haven't smoked a cigarette in their life. And all of them have been diagnosed with an advanced disease. Why? So there is a delay in diagnosis. There's delayed referrals by the primary physicians. There is lack of awareness about lung cancer. Most believe that only smokers get lung cancer. There's a huge stigma attached to this disease. There is the fear of not only biopsy, but the word cancer in itself. Then there is the dilemma of where to choose the treatment from. So basically, there's lack of easily accessible infrastructure. The small towns, the villages in India don't have enough setups that can help diagnose lung cancer. Another thing that each one of them has highlighted, especially Mohammed Rizwan Bhai, the time he takes to travel from Bhatinda to Mumbai, 1,500 kilometers, this time toxicity needs to be highlighted. So the time-related burden is very, very high, especially with people living in advanced disease, because they have to come for a follow-up every 3 months, every 4 months. Then each one of them has spoken about the financial toxicity. There are not enough government schemes. There is lack of awareness about these schemes. The cost of targeted therapy drugs and immunotherapy drugs, the diagnostics is far beyond the pocket of an average Indian family. The out-of-pocket expenditure that I want to highlight here are way too high. So each one of them, when they've traveled to any place for seeking treatment, that part of the treatment is not covered by any scheme. So the out-of-pocket expenditure sometimes exceeds the cost of the treatment. Then there is lack of psychosocial support. There is no knowledge. There is no knowledge of palliative care. There is inaccessibility to pain relief, end-of-life care. There's not enough support for clinical trials. And finally, why so many young women are getting diagnosed with lung cancer? So I'm going to highlight this by inviting another one of my panelists. She's a non-smoker. She's a young woman who was diagnosed with a rare form of lung cancer. And she's going to take us through her challenges. Suchismita is 27 years old. She is an engineer by profession. She was diagnosed at the age of 21. She relapsed within a year. And after that, her fortitude, her resilience and courage is for all to see. Suchi, welcome and thank you for being here. We're all eager to hear about your struggles, your challenges, and as a survivor, what you go through. Thank you very much.
Thank you, ma'am, for giving me an opportunity. Actually, I got diagnosed with lung cancer at the age of 21 years, as Vandana ji said. It not only affected me, but also my relationships and friendships. My father is my pillar of strength. Those who know me, they all know about my father, what he has done for me during my whole journey. However, it was not that easy for both of us, because though our family is very supportive, our friends are very supportive, but still society sympathizes, because they think that diagnosing at such a young age could be like such a difficult thing, because as Rasika said, what would be my next future decisions, are they all proper? So it not only broke my confidence, my self esteem, but also like physically and mentally, both the cases I was very much drained out. And also, whenever I used to see myself in the mirror with not even a single hair on my head, it was just like I had tears on my eyes, and every time I think about it, I get goosebumps. I had never smoked, as Vandana ji said, but still people used to ask, have you smoked? Have your father smoked? have anybody in your family smoke? So like that is a very big stigma. And also after, like, as I'm on remission, Vandana ji said, so people say that you had lung cancer, you don't look sick. Oh my God. So how do I look sick now? So like that is something, is like a stigma that is very, very much in India. And I think it can be just eradicated by awareness. And again, as everybody mentioned, going to a big facility hospital from a small town is really a challenge in India. I have to go for follow-ups every 4 months, and finding accommodation and expenses and all these, like, they are really burdenful for us, because though I come from a middle class family, but still sometimes we need to think about it. And also I had a recurrence. So, like, I went through 16 plus 16, 32 chemotherapies. But by God's grace, I am doing well now. And I thank each one of you to give me a platform here. And also, one more thing I would like to mention is that the care, the counseling, like, I went to a counselor, but I literally couldn't believe why I am going there, because I was not taught that cancer may also need counseling. So I think lack of support, lack of counseling is very much to be highlighted in India. Thank you so much for allowing me to keep my points. Thank you.
Thank you, Suchismita. The reason that we included Suchi in this discussion was that we need to highlight not only the challenges of the ones who are undergoing lung cancer treatment, but also of those who are survivors. I don't think we have enough survivorship programs in our country, and we need to be raising awareness about that. Thank you, Suchi, for being here. That was a very interesting, panel discussion. Before I move on to the next panel, which is of people from across the globe, subject matter experts and very esteemed speakers, I have an announcement to make. After we finish our panel 2 discussion, Lung Connect India is going to launch 2 new initiatives. I request all of you to stay connected with us. The next panel discussion is of eminent speakers, not only from India, but also from across the globe. It is only through collaboration that we can strengthen the cause of lung cancer across the globe, and also ensure that the patient's voice remains the center of focus. So I will quickly introduce our next panel to our listeners. The second panel has very eminent speakers. The first panelist is Dr. Kumar Prabhash. Sir is a very eminent and a renowned medical oncologist in India. He is Professor Medical Oncology, TMH Mumbai, presently working there. My next speaker is Dr. Yannick Romero. He is Senior Knowledge and Advocacy Manager within the Knowledge, Advocacy and Policy team at UICC. His work focuses on tobacco control globally, gathering and developing evidence-based information. He also leads the Lung Cancer Collaboration Secretariat. Our next panelist is Mr. Prabhat Sinha. Sir is Director, Public Government and Corporate Affairs, Boehringer Ingelheim Private Limited. Then we have Dr. Upal Basu. Sir is Executive Director, Research Longevity Foundation from the US. When I asked him how he would like to be introduced, he said as a patient advocate. Then we have a very young and dynamic medical oncologist from India, Dr. Akhil Kapoor. He's currently working at TMC Varanasi. My next panelist and the last one for the day is Dr. Jessamy Fox. She is the I hope I've got your name right, ma'am. She is the medical director of a UK-based lung cancer charitable organization, Roy Castle Lung Cancer Foundation, and also the secretary of the Global Lung Cancer Coalition. It's an honor to have all of you here. You've all been connected with us from the beginning, and most of you have heard about the challenges faced by the patients here today. So I now will start the discussion for our second panel. I will start with Yannick. Yannick, smoking still continues to be I think the major risk factor for lung cancer across the globe. I know UICC is doing a lot of work and has been involved in tobacco control. Can you take us through the impact smoking has on people across the globe, and what are the steps being taken by UICC for tobacco control? Thank you.
Thank you, Vandana. First, thank you for the opportunity to talk today. And I want to applaud actually the first panel for their resilience and for their courage to testify in front of the world. I think it's really great. Well, I don't know if I need to talk about tobacco control but yeah, I was really I'm moved by your testimonies, and it's really great to hear your voice, because that's the goal of UICC. Also, 40% of our membership organizations are patient organization. I think it's really important to raise their voice. Talking about, well, let's move to tobacco control and the work that we do. You know that, well, tobacco is the first killer regarding different diseases, and mostly cancer. 2 million people are dying because of lung cancer due to smoking. 80% in high-income countries, but we could see that shift in lower income countries. And we saw also that there is also an impact on lung cancer by air pollution, I mean indoor and outdoor air pollution. In terms of the work that we do at UICC is really collaborating, and you said it, collaborating with our members in 170 countries to raise awareness about tobacco control, because we all think that tobacco control is a thing of the past because of the FCTC treaty that went into force 20 years ago. But we still have 1.3 billion smokers in the world. There's still high prevalence. There are a lot of aspects that should be done by countries to raise awareness about the danger of this main risk factor for cancer and lung cancer specifically. The work that we do is really to raise awareness about the implementation of the key FCTC measures, which are raising taxes, most cost-effective measure. Currently, we have a program in Uganda and Kenya to build coalition to advocate toward the ministries and the government increasing the taxes. Why? Because we know that the name of the game is money for the government. What's the return of investment for them? If you put more money on the product that kills people, and you can return that and decrease the expenditure, the financial toxicity that you mentioned, and help the governments, that's really a win-win. I would say win-win-win for everyone, for the government, for the patients, and for the future of a country, because we all know that we advocate toward the countries to ban tobacco, any products, to the next generation. We work a lot on smoke-free environment, but also on advertising. So working with different organizations in terms of communications, in terms of influencers, and so on. So this is our work, and we have specific programs in different countries, and we also want to work with our patient organizations and all our organizations that can help us, because they have their feet on the ground, and they know the culture, they know the context. We cannot apply a model to everyone, but this is the work that we do. Thanks a lot.
Thank you, Yannick. I think there have been a lot of takeaways from what you've shared, and we at Lung Connect India are looking forward to our collaboration with you and learning how to implement, especially tobacco control in India. My next question is to Dr. Kumar Prabhash and Dr. Jessamine. Dr. Kumar, the panel of patients and caregivers, they all spoke about delayed diagnosis. Each one of them here, I would say stage 3 or stage 4. Why do you think this is happening? Why is there a delay in diagnosis? What can we do to enable, early screening so that early diagnosis is made? And what is the role of all of us here?
So there are a whole lot of reasons. why there is a delay in diagnosis. In general, lung cancer is diagnosed late in late stages across the world. And one of the important reason is that you have a lung cancer in lung where it resides in the thoracic cavity. It is a big cavity. It can store up to 6 liters of fluid. And by the time the nodule grows, unless it causes symptoms, it can keep growing till it throws some symptoms because of nodule there, or it throws symptoms because of the disease which goes to some other organ. And that is why, in spite of all the efforts, good number of patients, they are today also presents in advanced stage disease. Yes, there are various ways to pick them early. One of them is what you said, is to do implement screening, which is useful, and it appears that it leads to 20% reduction in lung cancer related mortality. So where feasible, it needs to be implemented. There are some things, at least in our society, which can be done before screening, and that is awareness. At this moment, if we see in our population, out of 100 odd lung cancer patient, 5 patients they get surgery done. And if you see the Western world, almost 20% of the patient used to get surgery done, in spite of in the era when screening was not there. What it suggests, we can have incremental leap in diagnosing the patients early if we increase the awareness and we have the healthcare resources and the facilities available for patients to able to access it. So yes, subsequently or at the same time, depending upon resources, yes, screening is important, but we need to be a bit careful about it, especially in a country like ours, where you do have a high rate of lung cancer infection because of tuberculosis and other granulomatous disease, because that can become a issue regarding having those biopsies to diagnose the disease. So yes, we need to work on multiple fronts in a country like ours to diagnose the patients early. And most important is, if we can remove the smoking, then whole lot of lung cancer can go away.
Thank you, Dr. Kumar. And we have to work with Yannick to ensure that we can raise awareness about smoking more, the hazards of smoking. Dr. Kumar, do LDCTs play a role here?
Can implement it is useful. Yeah.
Okay. Yeah. Gee, right. Dr. Fox, the same question to you. How is it in the UK? Are there delayed diagnoses, like Dr. Kumar said, worldwide? And
yeah, I mean, I completely agree with Dr. Kumar. I think late diagnosis is a really big problem for us in lung cancer. It is here in the United Kingdom, as it is in India and right across the globe. And he's absolutely right. There are kind of two ways to look at this, I think. One is about thinking about asymptomatic patients, so people who don't have any symptoms yet, and then to think about people who do have symptoms. And when we think about people with symptoms, a number of the patients have spoken very eloquently today about a lack of awareness about lung cancer, that if you have a change to your chest symptoms, you don't just sit there and think about it, you actually go and get something done, because the earlier you get diagnosed, the more likely that you will be picked up earlier when we can actually do something potentially curative to help you. But that level of awareness we just don't think is out there about lung cancer. So I think there's a lot that can be done. We do a lot in the United Kingdom, raising awareness on lung cancer, its signs and symptoms. At the moment, we have an initiative called Lung Cancer Awareness Month in November. And our organisation, the charity I work for here, and many others are engaged in trying to use this period of time as a focus for actually raising awareness about the disease and actually what can be done in terms of help and support down the line if you are unfortunate enough to be diagnosed with lung cancer. So I think in the symptomatic space, there's a lot that can be done around awareness raising amongst the general public and to some extent amongst physicians as well. One of your patients was talking there about, doctors just don't really think about it unless you're older gentleman and you've smoked for a very long period of time. I think there's a big message in there around, actually anyone can get lung cancer. It doesn't matter who you are, what age you are, or what you do, anyone can get lung cancer. And the earlier we pick it up, the better chance you have. So there's a big a lot we can do, I think, in the symptomatic space. If somebody has symptoms, encouraging to get support and diagnosed earlier. The second thing I talked about there was asymptomatic lung cancer, so before you have symptoms. And Dr. Kumar is absolutely right. We have an agreement on lung cancer screening here in the United Kingdom. It was recommended by our National Screening Committee about 18 months ago, and something that my organisation, which is very similar to lung cancer, to Lung Connect India, we've been engaged over years in campaigning for lung cancer screening, and we're now very much, focused on ensuring that we get implementation. In England, they are much further ahead in terms of a lung cancer screening programme. We probably have about 30% coverage in England at the moment. Scotland, Wales and Northern Ireland, our other 3 countries, are quite a bit behind. But there's an awful lot when you think about lung cancer screening that India can learn from countries like ours, which are probably a little bit further ahead in terms of how you do lung cancer screening, how you get to high-risk people. And so there's actually a big body of work out there. And I would mention the Lung Cancer Policy Network as a grouping, which on its website is a huge amount of very important tools which can help in terms of policy and actually the practical implementation of lung cancer screening, because it is it's a big program of work trying to get to people who have smoked or who currently smoked, who are at high risk, who actually fit the definition of high risk, and who will then enter into a low-dose CT screening programme. But already we've picked up in England over 5,000 people with lung cancer in our programme, of which 75% are stage 1 and 2. So 75% of the people we're picking up are actually early stage. And that's a huge, huge shift and a huge difference than we have in the normal route of getting diagnosed once you've had symptoms. So I think there's a lot to be gained by screening. But at the moment, it's about high-risk people. For us, it's 55 to 74-year-olds who currently smoke or have ever smoked. So there are a lot of people who do not fit that high-risk kind of category. So that whole focus on the symptomatic lung cancer is also really important as well. So I think there is a lot that can be done to ensure early detection of lung cancer and to support that as we go forward.
Thank you, Dr. Fox. A lot of things to learn from what you and your organization are doing. Screening, you've just highlighted how important screening is. And because of LDCTs and the other screening measures, you said 75% people that you screened have been picked up at stage 1 and 2, which automatically reduces mortality and increases the chances of survival. Thank you so much for sharing that. And India is an LMIC country. We have a long way to go. But hearing you talking to different stakeholders from across the globe gives us ideas how we can implement what you're doing here as well. Thank you so much. My next question is to Dr. Upal Basu from Longevity. Upal, thank you for being here. My question to you is, you've heard our patients and caregivers talk about their challenges. Are there similarities between the challenges faced by people here and those who are diagnosed in the US?
Vandana ji, first of all, thank you so much for the invitation. And thank you to our patients and caregivers for sharing their voice and their perspective. You are our North Star, and we do what we do for all of you. There are actually a lot of similarities between a patient's journey in the US and in India. I think a couple of things come to mind. First of all, Suchasmita was talking about the isolation that a patient feels when they've been diagnosed. I think whether you're diagnosed in the US, in India, or I would say any part of the world, I think the isolation that a person with lung cancer feels after they are diagnosed is universal. And I think the other piece to lung cancer is the stigma of the diagnosis. And I think that association with tobacco, and for younger people especially, I think that shock, as Suchasmita was talking about, that people are surprised to hear about a diagnosis, that stigma adds to that isolation. The second commonality I see across the US and India is the financial toxicity of a cancer diagnosis. Sadly, that is universal. In the United States, though we have an insurance service, I think the cost of cancer treatment which is in my mind different from the cost of living with cancer, that's incredibly high, whether you are in the United States or in India. And again, the traveling to major clinical centers, that's true as well. 80% of the US population, they're diagnosed in smaller community centers. And for them to receive specialty care, they also have to travel. And so that logistical burden, again, is universal. And I think all of us can do a better job of bringing care to the patient to really ease that burden of travel. And I would say the fourth thing that for me is also very personal is this lack of access to and stigmatization of palliative care. I think that's universal. I think even in the US or in India, I think patients are not really offered palliative care when they're diagnosed and throughout their journey. And Vandanaji, you brought up survivorship. I personally see palliative care as a huge piece of cancer survivorship. And even when palliative care is available, it's not offered to patients. And again, I feel that that's because of the stigma associated with palliative care.
Thank you, Upul, for, I think, talking about palliative care, because this is something very close to my heart, and palliative care not being integrated at the right time actually causes a lot of harm. We've seen when palliative care is integrated at the right time, it not only improves the quality of life, but sometimes patients with the terminal illness tend to live longer. So thank you for highlighting that. And I think across the globe, we need more focus on palliative care. Is there anything longevity is doing which can help us overcome these barriers?
One of the things, and again, I would say that lung cancer is global. We are a United States organization, but lung cancer is a global threat. A couple of things that I would say longevity, and I would say all patient organizations that we are doing is really sort of bringing together international stakeholders to solve some common issues. And when I say common issues, I think access to clinical trials is a common issue that is affecting all of us. How can we as a global community improve access to clinical trials? How can we increase infrastructure for clinical trials in low-income and middle-income countries? That's one piece. The second piece that groups such as ourselves we are doing is really awareness and increasing awareness, not just about lung cancer, but about risk factors, and also pushing people to think about not just tobacco, but other risk factors. And the thing that I'm particularly passionate about is the role of air pollution and the role of climate change. That's going to have a huge impact, not on just people today, but people who are going to be diagnosed with lung cancer in the future. So again, global advocacy groups working together to highlight some of these bigger global issues. And again, how can we as a global community work together to mitigate these threats?
Thank you, Upul. And you've just actually started my next question, which is for Dr. Akhil Kapoor. I know Dr. Akhil is very, very passionate about clinical trials. And Dr. Akhil, please talk us through what the scenario of clinical trial looks like in India. What can we do better and more so that there is better accessibility to clinical trials, and we are conducting more clinical trials, because that is the need of the hour. Dr. Akhil.
Yeah, thank you, ma'am, and the entire Connect Foundation. So it was very heartening to hear to the patients and their problems. And I always take pride that I'm a participant in Lung Connect Foundation as a clinician and as well as a patient advocate. So that is a huge good thing which has happened to me during my journey as a clinician. So, as we were discussing about clinical trials, so that is a thing which I learned from Kumar sir during my training at TMH Mumbai. And we know that now trials are very, very important. As we heard from some of the patients, that getting access to the drugs, even if they are available in the country, is difficult. So, what we can do, even we must all understand that even getting a good quality NGS is not accessible to a large proportion of the lung cancer patients, be it in stage 4 disease. So what we have done, we have tried to develop a model at TMH Varanasi. We have now around 8 trials in lung cancer, and out of these 5 trials are the first line settings. So what has happened? all the patients can undergo NGS through one or the other trial. And if the patient, for example, got tested in a trial for KRAS G12C, but has got a mutation through the NGS done from that trial, and it is now for MET exon, the patient can be shifted to next trial where the patient can be enrolled. Because we know available in the, but again, the cost is inaccessible to 99.9% of our patients, those who are not reimbursed. So that is the problem. So we have tried to develop a model. For example, around 90% of our patients who are diagnosed as stage 4 get screened in one or the other trial. So they get NGS done through the trials as a part of the screening work free of cost. And that is a good quality NGS, which covers most of the important targetable mutations. And they get enrolled in some or the other trial if they have mutations. And if they don't have mutations, they get enrolled in the immunotherapy trials. That is what we have tried to develop. So that brings access to the medications, good drugs, and as proper, because we know in all the guidelines it is mentioned a clinical trial is the best, one of the best treatment which can happen for lung cancer. It is good for research, it is good for the patient, good for the clinician as well. So that is what we want to understand and listen. So we must understand, and this needs to carry forward. So if problem, how can we do better? Awareness about the trials is important. I know that a lot major proportion of the patients refuse for participating in the trial because they think that they might become guinea pig in the trial. So that is a problem. That is why we need to educate patients. We need to spread the word in the community that and clinical trial is for the benefit of the patient, not for the benefit of the clinician, not for the benefit of any particular hospital or anything. So this is for the benefit of the patients, which we are trying to do. And sole motto is to give the patient so both good. So that is one important point. Second part is that awareness about patient is another thing. Awareness among clinicians. If one my colleague who is working around 500 kilometers from here, but he is aware about my trials. For example, I get referrals for trial from 1700 kilometers of India. So for example, we got a patient who traveled all the way from Kerala to get enrolled in a trial at Varanasi, traveling 1700 kilometers. We got another patient who traveled from all the way from Pakistan border, Indo-Pakistan border, to get enrolled in trial at Varanasi. So this is what is happening. But though it involves travel, but the patients are happy because they are able to get the best quality treatment and the enrollment in trial. And we have a lot of success stories for the patients. So awareness among the clinicians is important because the if for example a testing was done, patient got some mutation, specific mutation for which we know that there's a trial available in, and not only in Varanasi but other centers also. Clinicians should make themselves aware and should refer the patient for the same. This will not only enhance participation in the trial, but what will happen? The enrollment in the trials will improve because these trials are most of the time industry sponsored. They want good amount of enrollment and good amount of follow-up. So if there is enrollment is good, the industries will be happy to give more and more trials to our country. So that is what is important. So it is a chain reaction. The clinicians are aware, the patients are aware. There is a trial referral system which has been set up. So it will lead to enrollment in the trials. I don't want to say only one center should become the specific for conducting trials, because this will have regional disparities and other problems. So for example, if I have three important trials running for lung cancer, let another trial, three trials for related to lung cancer be running in somewhere around 300 or 400 kilometers from here, so that even if I have a patient who has been diagnosed to have that particular mutation, I can also refer the patient to that particular center. So that way it becomes a mutual give and take for all the centers, and it will be win and win situation for both clinicians and the patients and their caregivers alike. So that is what we need to do, and there should be a setup of inter institutional setups where trial referrals should be promoted. That is what is important, and this is not only for government institutes but also for the private institutions, so that they can take participate in more and more trials.
Thank you, Dr. Akhil. I think that was very informative, and I take a lot of pride in knowing that a few trials recently have been very successful in India, and they've been globally accepted. And TMH Mumbai and TMH Varanasi has played a very important role in it. Dr. Kumar and yourself. Thank you. And I think one very important point that you have raised is creating nodal centers, regional centers, so that more trials are happening and they become more accessible. Because sometimes there is a mental block of traveling from, say, West Bengal to Varanasi, or maybe from down south to Mumbai. So we need more regional nodal centers where trials can happen. Thank you, Dr. Akhil, for your views on clinical trials. My next question is addressed to, I think, all the participants here. Younger women, I read a recent statistic which said 1 in 5 women diagnosed with lung cancer is a non-smoker. Why is this happening? Dr. Kumar.
Kumar sir has left.
Oh, okay. I'll take this question to Dr. Fox, Dr. Jessamy Fox.
So I think the issue of non-smoking lung cancer is a really interesting one. I can't speak for the data in India, but here in the United Kingdom, we know that somewhere between 20 and 25% of lung cancer has got nothing to do with smoking. And we are certainly picking up younger people who are getting lung cancer. And I think having found a lot of the targets that we now have, the biological targets, some of which are associated with non-smoking lung cancer, I think it's become something that we're much more aware of. I would imagine that those people were actually always there. It's just that some of the things your patients were saying about young people and just not suspecting that those people would have lung cancer, they may well have died before they were actually diagnosed before, or they were diagnosed so late that they were people that just weren't really being picked up, or people that before there were therapies to help that we just weren't really aware of. So I think there is a lot more awareness now of young people and non-smoking, or younger people and non-smoking lung cancer. And I think the fact that a lot of those new therapies are keeping people alive for much, much longer than we ever saw. I mean, I've been involved in lung cancer advocacy for 25 years. And it's only in the last 10 to 15 years that we've seen people who, with advanced disease, because of these new biological target therapies, that we're seeing these people survive for an awful lot longer. And I think that that's been a hugely positive development. There are clearly huge challenges around biomarker testing, around that being set up. Clearly, from the discussion we've had, there are big issues around costs in everybody's health systems around that testing, and then around actually accessing the drugs. But the fact that the science is improving things, I think, is really quite exciting and continues to be so. So I think there's probably a lot more awareness now about non-smoking lung cancer, and certainly in younger people. But it's probably always been there. But it's just that we now have therapies that are active, and we need to actually seek out those people and make sure that they get the right and appropriate treatment.
Thank you, Dr. Fox. Dr. Uppal, I would like to get your perspective on it.
I would echo Dr. Fox's sentiments. And the only thing I would add, Vandanaji, is I think over the past couple of years, I think the research community has understood better what the biology of lung cancer in non-smokers is as compared to those with tobacco exposure, and how it's different. And 2 years ago, there was this very important piece of work that clearly demonstrated that lung cancer in younger people who reside in high pollution areas, they tend to have a certain type of biomarker, the EGFR mutation. And what Dr. Fox mentioned, that these mutations tend to show up in people who are younger. And this study clearly linked air pollution to the development of these biomarker-driven lung cancers. And I think these types of studies are sort of really helping us understand these links as to why lung cancer is showing up in younger women, and equally importantly, how can we diagnose them and how can we treat them. And I'll echo the importance of biomarker testing, because it's very clear that lung cancer in younger people without any kind of tobacco exposure, they tend to have these specific biomarkers, these driver mutations that respond very well to these targeted therapies. So I think it's sort of, again, that chain reaction that Dr. Kapoor was talking about, that biomarker testing has to become the norm to help ensure that younger people have access to the right treatment.
Dr. Akhil, your perspective here would also
Yeah,
be
ma'am.
very enlightening. Yeah.
Yeah. So this was being discussed at WCLC this year in detail, actually. So there are some projects which are going to happen in India specific for young lung cancers, and one of the center in India has got grant to conduct a study for the same. Yes, we have also identified some of the genes which are affecting families with generations of lung cancer. One of them is T790M, and we have identified them when it is presenting at the upfront itself. T790M usually is called a resistant mutation to treatment like first line or second line EGFR. But now we know that T790M is one of the genes which are implicated for lung cancer transmission from generation to generation. So that is also responsible for some of the cases for genetic lung cancer. Though this is a very evolving field, and we only understand a tip of the iceberg presently, we need to dwell into it further. And as Mr. Uppal was highlighting, yes, it is this data is already in the public domain that pollution-linked lung cancers are on the rise. And that is why Southeast Asian countries, not only India, all the Southeast Asian countries are seeing a gross increase in lung cancer. And we know that EGFR mutation is one of the most common mutation in Southeast Asian countries. This is just 16% in US as compared to 26 to 36% in our country. And our center reported a mutation rate of 46% EGFR out of the total lung cancer patients tested. So that is the highlight today we need to identify and to treat so that
Oh,
we can do some.
goodness.
Yeah.
That's so scary, Dr. Akhil, in a country like India where air pollution seems to be the norm these days. It's very, very scary. Thank you for your views and perspectives. My next question is to Mr. Prabhat Sinha. Prabhatji,
Yeah.
my question to you is, do the patients have a choice to quality treatment and safety? In healthcare, in your opinion, where does the patient's voice matter?
Thank you, Vandanaji. First of all, I think I should give a huge compliment to Rizwan Bhai, Rasika, Suchishmita, Ashokji, and Shreya. I think there cannot be a better way to start these kind of discussion with the voice of people. And I think this is an outcome of Lung Connect, I should say. Having a small volunteer with Lung Connect for last few years, I think today, if we see these 5 volunteers,
Prabhatji, I think there seems to
clinical
be
trial,
some...
access to information, access to care, diagnosis, counseling, access to specialists. I think there are multiple things, I think, where the need to involve and engage patient advocates is essential. Unfortunately, in our country, we are very, very far behind on this journey, but good that we have started on this journey. And forums like this, support of institutions like Tata Hospital, for example, has given impetus to this whole initiative. A lot of companies in India, where I have been fortunate to work in past, for example, Novartis, Pfizer, to name a few, I think have also come forward and started supporting these organizations and these patient advocates. So what I like to say that definitely there is a place, but what is needed and what is required is how fast and how strongly we support this. Otherwise, the every month, every day we are losing somebody. We just talked about losing, for example, Raviji, whom we all remember today whenever we reconnect on forum like this. We don't want to lose people like him and many, right? And that's why there is a need to accelerate this whole process. And that will come once we start trusting, acknowledging, and appreciating the voice of these patients. That is essential. It's at every place. And that is where when we see today, this forum, for example, I was just calculating, it's almost 20,000 minutes Lung Connect has given a platform for patients. 20,000 minutes. It's not a small. And when we see that from across the country, how people have come. So when it comes to access to information, yes, this is access to simple starts with access to information. there are many places. Ayushman Bharat we talked about. I think India, while we are discussing about Lung Connect, the healthcare in India also is in a very transitional stage. With we have been a country for years with out-of-pocket market where we have to pay for our own treatment from our pocket, and that's why the cost comes first on many things, and then we start thinking about only, let's say, the cost of hospital or cost of drug, but there are many other costs which is involved. Why in our country we get access means we diagnose patients at stage 3 and stage 4, because this unnecessarily also increases the cost of either a personal treatment or the treatment cost for the healthcare system. And that's why what Dr. Kumar and everybody talked about the early diagnosis, so that the healthcare can also take up this cost. The voice of patients, for example, in a program like Ayushman Bharat, I think it's very encouraging to see how Ayushman Bharat is slowly increasing. I think it's a journey where, but again, how fast we can see some of the very basic targeted therapy being part of the Ayushman Bharat. It is possible with the treatment cap, what is there now, 500,000 Indian rupee. I think a lot of drugs now can be possible, and there are multiple things. If I give you a parallel with, let's say, the way government is looking at rare disease, for example, they have started talking about negotiating price with the pharma organizations to provide access to a wider population. So we need to do something very different than what we have been doing for years. If we really want to decentralize cancer care, for example, how Varanasi, in the leadership of Dr. Akhil and many others in Varanasi, how it has really taken care of patients coming from eastern part of the country. They may not need to come to Mumbai, for example. They can get access of specialist doctor and many other things in Varanasi itself, Muzaffarpur. So it's many places. So I think in all the policy discussion, what is required is to appreciate and acknowledge that the patient is like in our clinical trial places, and many places we say that they is a lay person. They are not lay person. They come with the expertise, right? In their own, every example itself gives a lot of insights. So what is important is that we all acknowledge, appreciate that there is something very essential that we can get from these patients. And we have to sometime leave that chair for them. That is very important, because that also is important, that if there is a seat, I should vacate that seat for somebody who is more authentic, more credible to talk about it. And I think Lung Connect, I think, is giving that platform, bringing such voices. Now, today, if we see 5, and I know there are more than 5, there are many in various places who has come. I see Suchishmita smiling, but when I see Suchishmita for 4 years back, 3 years, 4, and what today she is. Now, these are the people who have to take the baton going forward, and others, I say, we have to vacate the seat for them, take them to a place where they need to make themselves heard. So that is what I would like to say at this point of time. But kudos to Lung Connect again for, empowering them, enabling them, giving this space. I think that is something which is praiseworthy. Thank you.
Thank you for supporting us, Prabhaji. And something that you just said is we're going to take it back, the entire team, that the chair needs to be vacated for them so that they can make their voice felt heard. That is very, very important. Thank you, Prabhaji. I am going back to Yannick now.
Couldn't hear your question. If you were asking a question.
Yeah, yes, we've spoken about smoking, and but we also need to talk about e-cigarettes and vaping as a risk factor. I know of a lot of young people personally who say vaping does not cause any risk for us. And about a month back, I got a WhatsApp forward which said, kindly support vaping, which is being considered, which is being banned. So, yeah. I mean, actually, this is happening. People who are using e-cigarettes and who are vaping, they think it is very safe. Tell us about how bad they are, Yannick.
Well, unlike tobacco, e-cigarettes are really new. Well, really new, 10 years. So as you know, like lung cancer, and every cancer takes a while to declare and to trigger. So we at UICC, what we do is really to advocate for disseminating and also increasing research on those products. But e-cigarettes are made of, it's not vapor, it's not water, it's made of chemicals that can be harmful, and those and fine particles and so on. There is more and more evidence that they trigger lung diseases. We still don't know about lung cancer. There are some clues about their effect on lung cancer, but we are really cautious, more than cautious. And the thing also is that most of the e-cigarette producers or investors are coming from the tobacco industry. And they use the same playbook that they used and they are still using to make these products, I would say, sexy for the next generation, because we have to hook a new generation. We have to hook 10 years old, 12 years old kids, because we have to renew the base of their consumers. And that's it. So we have to be careful with the cigarettes in terms of, well, we base our work on evidence, but also we know that behind it, there is a tobacco industry who wants to increase their profit. Even if they said that they want to go smoke-free, they are still building new factories in every country for tobacco, for any tobacco product. So this is one part of the work that we do also, is to counter the industry claims about e-cigarettes, the claims from the front groups that are financed by the tobacco industry and e-cigarette industry. So I'm always careful with people who are saying that a product could be safe and it's backed by the tobacco industry. And I know that in India it's banned clearly since 5 years almost, and they try by using black market and so on, and they try with other products like pouches and so on, and it's shown that it's as smokeless tobacco and chewing tobacco, it triggers different types of cancers. Thank you.
Thank you. Like you rightly said, it's banned in India, but I would say what is banned in India is being pushed more by the tobacco industry, and it becomes that much more fascinating for people, which is very sad and which is very scary. More younger people are resorting to, because like you said, it is more stylish, it is more sexy, it is it just suits their personality to be doing something like this. And we collectively need to come together and talk more about how harmful the smokeless cigarettes. We need to do that. Thank you, Yannick, for your, I think this is such a useful information that you've shared. Now I come to my last question, and I'm going to begin with you only. How can we come together and strengthen the cause of lung cancer globally?
We heard a lot about access today. I really like that. And we started to think about what we call the lung cancer care pathway, which is really putting all what we have heard today, which is prevention on risk factors, specifically tobacco and so on, early detection and screening, access to treatment, supportive and palliative care, and putting together and really advocating for a lung cancer care pathway which integrates the patient also at the center. I think it's really key for that, really developing that. And we do that through our global advocacy and policy work, which is work with the governments, WHO also, and we make them accountable to really put in place policies that take into account the patients and the whole lung cancer care pathway. We've done that with Cancer Control Continuum, which is from prevention until survivorship, including finance, governance, and so on. And by using that care pathway, we can better collaborate all together, putting all the different pieces together. So we can use awareness campaigns as we've done. We use ourselves the Lung Cancer Awareness Month, so November, as Dr. Fox mentioned. Also, World Cancer Day is really a good opportunity also to raise awareness. So we have that public-facing awareness, but also awareness toward the policymakers. showing the evidence from the experts. I think it's really key. And also making them accountable. They have to, this is the population, this is their population, they have to take care. Access to universal health care, I think it's key. We have heard about financial toxicity, out-of-pocket expenditure, and so on. So we advocate toward having access to universal health care. We have heard about the US, India, similar, but you have countries where you have universal healthcare and you have less out-of-pocket expenditure and so on, access to treatment. Just to mention that we have an initiative called the ATOM Coalition, Access to Oncology Medicine. I invite you to just go on the uicc.org and look at the ATOM Coalition because we work with different partners, private partners and so on, to have access to certain medicines in low and middle income countries regarding different cancer types and so on. So that could be also helpful. But yeah, collaboration, well, we need to collaborate with the different providers, with the governments, the NGOs, the patients and so on, increase about the stigma around the lung cancer patients. We've heard about it from the different patients and so on, using all the different channels that we might have and advocate toward everyone. And that's it. Thanks.
Thank you so much. Dr. Uppal, the same question to you.
We were talking about medicines. One thing that really comes to mind, Vandana ji, is I feel policymakers and all over the world, I think, are a little bit behind with the science of lung cancer. We've made so much of advances with precision medicine, and we heard from Dr. Kapoor about all these new drugs. But I feel that one of the things that we can do as a global community is to bring multilateral organizations like the WHO together, all of us together, and really sort of remind them that we need to be rethinking about how, say, the WHO's essential medicines list is defined. It's really lagging behind where the science is concerned. And I think this is a place where all of us can really come together to inform policymakers about how cancer has really changed and how policy needs to keep up with the science.
Thank you so much, Dr. Fox. What are your views about?
I think just very briefly, I mean, I think this kind of discussion is extremely important. And I think we can all learn from each other. I've learned a few things today, and I'm assuming most people on the call will have learned something as well. And I think we all have our own expertise. We all have our own longevity, however long that is, in terms of organisations that we've been associated with. My organisation in the UK is now 30 years old. So we have a huge array of information and support materials and all sorts of other things that we've done over that period of time, which you're freely available to share with everybody. So and your organisation the same. So I think actually having that dialogue and that kind of open discussion and that sense of networking and building capacity is actually really important.
Thank you so much, Dr. Akhil.
Yeah, so I completely agree. There is a lot which we learned today, and we keep on learning. This is a field which is evolving, and I think mutual understanding and cooperation is extremely useful. And as already highlighted, hearing the voice of the patients and making them the voice of the organization is the key for the proper growth of any such organization, so that we can keep on involving the policymakers and the health policy developments. So this is really important, and I hope we will be able to do that in the near future very shortly. Thank you.
Prabhat ji, I think Vandana ji network.
Hello.
Yeah.
Hanji.
Now
Yeah. No audible. Thank you, Dr. Akhil. Well, closing remarks from Prabhatji about the same question. Prabhatji.
I think it's well spoken by everybody. I just want to reiterate one is the multi-sectoral partnership. We talked about multi-sectoral partnership, but I think this is a high time. Still, we are far away from what we call a multi-sectoral partnership. If we see India, for example, there are various ministries, various stakeholders, but I think we are much far away from what we call stakeholders coming together. And I think forums like this, as Fox also highlighted, I think we need to bring stakeholders together, nurture these partnerships, and most importantly, allow to sit patient advocates, patient organizations on a driving seat. Then we will see the things moving faster, and we will reach towards what our aspiration.
Thank you so much. A lot of takeaways for us at Lung Connect. Now I'm going to invite a communication manager, Mr. Amber Srivastav, to launch our two initiatives. Kindly stay connected. We are very excited about these two initiatives, and hopefully you will be too after seeing what we are going to do next. Over to you, Amber.
Thank you, Vandana. I can see on your face that I have to finish quick. So I won't take much time. So hello, everyone. We are very excited to announce that we are starting our latest initiative, which is the Buddy program, which eventually all of you are going to inaugurate at the end of the later part of the meeting. So I won't take much time, but I'll give you a brief overview about the program. As the name suggests, this program is all about fostering one-to-one connection, sharing experiences, and empowering each other. The two very important thing that this program is unique in India, and as per my knowledge in South Asian countries also, and it is completely free of charge. There is no fee connected to that. So actually in the past, we have found that when patients connect with us, they benefit greatly from talking to others who have gone through the similar experiences. And this is especially true in the beginning stage of their journey. So to streamline this process, because we have been doing this since few years, so just to streamline this process, we thought to start this program, this process as a program. So what we are doing is that we have set up a registration form. I'm quickly finishing everything. So we have set up a registration form on our portal. We'll take entries from there, and based on patients' language, condition, even location. Because location, why? Because in India is a very big country with various culture and language. You have seen that our patient and caregiver spoke in 3 languages. So sometimes this culture part also plays a role when we support our friends. So what we'll do, we'll match all these things with our trained buddy, and that person will answer the queries as much as possible. We are also inviting people to become a buddy on the same portal with a different sort of registration form. So then we'll take entries from there. We'll train them so that they can become buddy for the other patient. And obviously there are a guideline connected to that. There is a do's and don'ts, which you can see in detail in our portal. So actually what we are trying to cover in this program, I'll give you a few quick pointers, like patient navigation, administrative support, coordination in healthcare, and very frequently asked questions, side effect management, and financial guidance. So what we'll do in financial guidance, that we'll connect patient to the different organization and foundation who help patients in financially. So this is a brief introduction about the program. So I would like to invite everyone who is present in this meeting to launch this buddy program officially. As we don't have any virtual ribbon to cut, I would request everyone to send us a thumb icon. You can find that thumb icon drop down menu down in the Zoom window. And I'm also inviting everyone who's watching us on our YouTube channel. Please send us some love with thumbs up icon, and it's community is driven because all of you. Yes, we can clap. So I'm sure this Zoom will block the sound of clap, assuming it's a noise, but actually it's a voice. So you can clap. I have another another thing to share that Pfizer has created a wonderful video about ALK positive. It's a very informative and fantastic video. We say a lot of thanks to them for this great thing. So what we are doing is that we are releasing this video today itself on our social media platform. You can watch that video on obviously on Pfizer's social media handle also. And one more thing is that we also want to say thanks, a big thanks to AstraZeneca, who is supporting us throughout. Because obviously it's a non-profit organization and we need people like you to support us. Yeah, so can someone play a video for a minute? If Vandana, you allow just 1 minute.
Only for a minute, please. Over time, only for a minute. Thank you so much.
I have been feeling so exhausted lately, and the cough is not getting better. Doctor, what did my test results show? After being diagnosed with non-small cell lung cancer,
your test results show that your lung cancer is anaplastic lymphoma kinase, ALK positive, meaning it has ALK gene mutation. There are advanced medicines available now, which specifically target this mutation. These advanced medicines are ALK tyrosine kinase inhibitors, ALK TKIs.
ALK TKIs, what are they? And how will they help me?
ALK TKIs are a type of targeted therapy or medication designed specifically for patients with ALK positive non-small cell lung cancer.
Okay, so that's the video which you can watch on social media platform, Lung Connects and Pfizer's social media platform. So thank you, everyone. Thank you so much. Vandana, over to you.
Thank you. Thank you. Thank you, Amber. And thank you for keeping us within time and not going way too over time. I thank everybody present here today for their support, for their wonderful insights. And I look forward to our continued discussion to strengthen the cause of lung cancer and advocacy across the globe. I'm going to hand over to Rasika for the closing remarks. Rasika.
Thank you, Vandana ji. So a heartfelt thank you to all of our esteemed panelists for joining us today. I'm deeply inspired by the richness and diversity of perspectives shared during this webinar. Your presence made this meaningful dialogue possible. And on behalf of Lung Connect India Foundation, we are truly grateful. This webinar marks an important step towards strengthening the cause of global advocacy for lung cancer, and your contributions have undoubtedly added immense value to this effort. Thank you once again for your time, and wishing everyone a wonderful morning, a productive day, or